Afternoon. Gerald Sotsky is board certified by the American Board of Internal Medicine and Subspecialty Board of Cardiovascular Disease. He received his education at Mount Sinai School of Medicine in New York and completed his residency and fellowship at Mount Sinai Medical Center. Dr. Sotsky is the chair of cardiac services for Valley Medical Group, and his practice is located in Ridgewood. Thank you, Dr. Sotsky.
Good afternoon, everyone. Thanks for joining me. I'm going to talk about COVID-19, which obviously everybody's heard quite a bit about, and some of the issues that, as it relates to heart disease. I'm probably sort of uniquely, able to do this because my wife's an infectious disease doctor, so the infectious part I probably learned from her, and the rest is for me. Next slide. So when we look at the effect, as you all know, COVID is a disease which really predominantly affects the respiratory system. A lot of the concerns with COVID were pneumonias and respiratory infections and so on. But COVID can affect multiple organ systems in the body, one of which is the cardiovascular system. We measure cardiac injury by measuring a protein unique to heart muscle called troponin. It's the protein that we measure when we look for problems with circulation to the heart or with the muscle of the heart and so on. And it's a measure, it can be used to measure injury to the heart. Next. This is kind of a complicated slide, which shows the multiple types of heart muscle injury that can occur related to COVID. I'm not sure if you can see my arrow, but there are various different types of injury, and I'm gonna talk a little bit about some of them. Next. So the one that got the most press is myocarditis, and I'm going to talk more in detail about that. Myocarditis is an infection of the heart. It's usually caused by viral syndromes, and there are numerous viruses which can do it, and COVID is one of them. COVID is somewhat unique with myocarditis in that other viruses tend to affect the heart muscle cells directly, whereas COVID affects sort of the environment of heart muscle cells, but there's not been proof that the virus directly infiltrates the muscle. And there are numerous other types of heart injury, and I'm going to sort of go through them one by one. Next. Stress cardiomyopathy is a condition which has a lot of different names. One of them is called broken heart syndrome. And the reason for that is that this is a condition that's often seen in people under extreme physical or emotional stress. It's actually mostly seen in postmenopausal women, usually after an extreme either emotional event or physical event. And people come in mimicking signs of a heart attack, often with chest pain, EKGs that look like heart attacks. And heart enzymes tend to be elevated, although not as high as true heart attacks. It's called Takotsubo. If you go to the next slide. Takotsubo is not the name of the person who described it, but actually Takotsubo refers to an octopus trap, which you see on the right side. And the heart muscle, when it's damaged, the type of damage to the muscle on an echocardiogram resembles this type of trap. In COVID, we're seeing a fair number of people, many more than we've seen with other infectious illnesses or viruses, presenting with this type of injury to the heart muscle. The good news is that these people will, if we can support them long enough, will generally have full recovery of their heart muscle. Next. Type 1 myocardial infarction is a typical heart attack. As you can see in the cartoon on the right side, this is usually caused by a blockage in an artery leading to the heart, resulting in death of heart muscle. Interestingly enough, we did not see a lot of type 1 myocardial infarctions in people with acute COVID. Next. The heart, as you can see in the cartoon, the heart is a supply and demand organ. The supply of blood is through the coronary arteries, but there are many different demands on the heart, which increase the need for oxygen and blood supply. we saw a lot of so-called type 2 myocardial infarctions or heart attacks related to an imbalance of supply and demand. And this occurred because of the stress of the infection or inflammation, which caused damage to the heart muscle. Next. Pulmonary embolism is an injury to the lung related to a clot that forms within the pulmonary artery, which is the large artery that feeds blood into the lungs. The cartoon shows that clot in the circle. You can see we call a saddle embolus, which is blocking a large segment of the circulation. In COVID, the reasoning for this and also deep vein thrombosis or clots in the legs was related to the virus causing a tremendous increase in the coagulability of blood. Next. This is one of the most feared complications of COVID we call cytokine storm. Cytokines are proteins that are released by the body due to an immune activation after COVID infection. So cytokines are a normal response to infection. The problem is that with an excessive release of cytokines, you can have a massive inflammatory response, which can cause damage to multiple healthy tissues and organs, including the heart. Many of the people who ended up in intensive care units on ventilators were related to this cytokine storm. Next. So cytokine storm in the heart can cause arrhythmias. It can cause myocarditis or pericarditis and inflammation of the sac around the heart. It could cause congestive heart failure and also could lead to hypercoagulability or high clotting potential, which could cause heart attack, stroke, pulmonary embolism, or deep vein thrombosis. A lot of the therapies and a lot of the early treatments back in February and March and April of 2020 were directed at trying to reduce the immune response to COVID and prevent cytokine storm. Next. So what about people who ended up in the hospital? How much of this were we seeing, and what was the impact of myocardial injury in patients hospitalized with COVID infection? Next. This shows the association of myocardial injury, and we measured that by levels of troponin. And what we found was the more severe the disease, the worse the myocardial injury. So 20% of hospitalized patients were found to have evidence of myocardial or heart injury, but 40% of moderate to severe or critically ill patients had evidence for heart injury. Next. And we saw that in all the bad complications of COVID. People with ARDS, which is a severe pulmonary leaking of fluid that caused respiratory failure, mechanical ventilation, which everybody's heard about the need for ventilators, serious or life-threatening arrhythmias, and even death. And as you can see, in people, the blue bar is showing you that people with COVID who are severely ill with COVID at high levels or high risk of ARDS, of death, of needing to be on a ventilator. So myocardial injury was an important component or marker for severity of disease. Next. Now, one thing that's important is who's at risk for this. And what we found is people with chronic diseases were often the ones who ended up having problems with COVID. So people with atrial fibrillation or coronary artery disease, of course, cancer, chronic kidney disease, COPD, heart failure, hypertension, these are the people who are at highest risk of having myocardial injury during COVID infection. So the early treatments were directed at these people, and of course the early vaccine programs were immediately directed at older people and people with these so-called comorbidities, and continue to be so. Next. So what about myocarditis? This is a big concern with COVID. This is a virus that can infect the milieu of the heart. So next slide. This is a large study in the United States. They looked at over 36 million people from over 900 hospitals in this country. About 4% of people, or almost 1.5 million people, had a diagnosis of COVID. And of that, a small percentage, 0.01%, had a diagnosis of myocarditis. But people with myocarditis had a 42% chance of having a history of COVID. So this is clearly was a problem in people with COVID. The risk of myocarditis in a person with COVID was 0.146%, but a person without COVID was 0.009%. Next slide. So there was a large increase in the amount of myocarditis in people with COVID. So is this a direct cause, or is this just an association? Is this a coincidence? This is a chart showing on the left the months in 2019 where very, very small numbers of myocarditis, and on the right, 2020, you can see the marked increase in COVID cases that occurred early in the pandemic. So it appears that COVID is a direct cause of myocarditis. Next. And as I said, patients with COVID have a 16 times risk of having myocarditis compared to people in the general public. And again, just to remind you, myocarditis is an infection of the heart muscle. It can cause severe dysfunction of the muscle and congestive heart failure, dangerous and potentially lethal arrhythmias. This is a bad disease that has a very high risk of serious complications or even death. Next. So this is another large review published in the American Journal of Emergency Medicine. Next. And this is to make the point that what I had mentioned earlier is this broken heart or Takotsubo cardiomyopathy. A fair number of people who were thought to have COVID-associated myocarditis, in fact, had this broken heart syndrome. So these are the two dangerous conditions that we worry about. Next. Next slide. So how bad is this? Well, it was pretty bad. In patients who were hospitalized, the mortality of COVID-19 was somewhere between 1% and 3%. People with severe COVID-19, and these are people ending up in intensive care units or close to intensive care units, over 17% died. People with COVID myocarditis in the hospital, 14% died. So the mortality of COVID myocarditis mirrors the mortality of severe COVID. So again, people in the hospital with this is a bad disease. Next. So the question is this always a bad disease, or is it just in hospitalized people? So two very interesting studies were done. One looked at we decided to, scientists decided to look at some of the healthiest people, and they looked at competitive athletes. This is a registry from the Big Ten, so these are college kids who had COVID. Next. And a little hard to see on this, but what they found was they looked at almost over 9,000 Big Ten athletes. So these are all comers, men and women, all sports. And what they found was out of the 9,200, about 2,800 were positive for COVID, of which 2,400 had cardiac evaluations. 9 had actual clinical evidence of myocarditis. They had symptoms, chest pain, shortness of breath, but 28 had subclinical, meaning these are people really who did not have symptoms at all, and yet were found by cardiac testing to have evidence of myocarditis. It's important because it shows that many of these, many people probably have had low-grade versions of this and then will get better. And in fact, these Big Ten athletes, the large majority of these did fine. They rested and did fine. Next. Another study, this is a similar showing the 27 and 13 athletes. Really depended on how you look for it. Some were looked for just by clinical methods like EKG and an echo, and some went as far as doing a cardiac MRI, which had a much more discriminating look and was able to pick up cases of myocarditis many of whom were completely asymptomatic. Next. This is another interesting study that looked at professional athletes. Next. They looked at almost 800 athletes. Now, in this group, almost all of them were men. These are young men. These are professional, NBA, professional basketball, professional football, professional soccer, and so on. And what they found was 30 of the 789 had abnormal testing, of which about 8 or 10 of them actually had evidence for really significant either myocarditis or pericarditis. So this is a much more widespread problem, most of whom do not have the severity I showed before, needing hospitalization and having life-threatening conditions. In fact, none of these athletes were actually admitted to the hospital, and a small handful, the 5, only those 5 were kept from playing their sport for whatever period of time, 6 months or a year, and none of them died. All of them did okay. This all resolved. This all resolved, and they went back to their normal, activities. Next. Now, a big issue has been the vaccine and the question of myocarditis being caused by the vaccine. So this next slide. So this is a study. This is a very large study looking at over 190 million individuals who received over 350 million doses of an mRNA-based COVID-19 vaccine. So these are the standard Pfizer or Moderna vaccines. Almost 2,000 reports of myocarditis were received by the group that looked at them after receiving at least 1 dose of the vaccine, of which almost 1,600 met clear definition for probable or confirmed myocarditis. Next. About 18% occurred after the first dose, usually within 2 to 3 days, but the large majority occurred after the second dose, over 80%. And again, symptoms occurred after 2 days. Next. What was found was that the predominance in this case were found in young men, and the largest number found in males age 16 or 17 after the second dose. They were found to have 106 cases per million doses, compared to what would have been expected to be 1.34 cases, so almost 100 times increase in the number of cases of myocarditis in this group of young men. Next slide. So this is another article looking at suspected myocarditis after vaccination. Next. So again, and this is the Pfizer vaccine, again found that the large majority, in this case, 90% occurred after the second dose. Most of them presented with chest pain, which is not surprising. Now, in this study, many of these ended up admitted to the hospital, and a lot of that had to do with really the concern of what may be the natural history of this disease. Would they deteriorate and do poorly? But in fact, they didn't. The large majority got better. They're showing you that the number of days in the hospital, the average was 2 days in the hospital. Almost none required, a small percentage required the ICU. Almost none required advanced support devices or drugs, and they got better and went home. Next. And this goes through some of the imaging that we do, EKG, echo, and even MRI, with many of these showing the abnormalities consistent with myocarditis. Next. Another study, next. So again, just to make the point that this was predominantly a disease of adolescent males, and from the disease itself, post-COVID myocarditis occurred about 7 per million in that demographic, whereas post-vaccine myocarditis occurred almost 100 per million. So still a small number, but by a marked increase compared to the disease itself. So in this case, from the standpoint of myocarditis, the treatment or the vaccine caused more of this condition than the disease. So obviously the question came up is, should we be vaccinating young men? Next. So this was an important question, and this author Gargano, what he did was to look at he looked at really this entire demographic of young men from age 12 to 29. What he found was COVID-19 itself did in fact have a certain level of high morbidity or even mortality in this group. 0.1 to 1 per 100,000 would either get very ill or in fact could die. So the expectation was if you vaccinated all of them, you would have somewhere around 39 to 47 cases per 100,000 of vaccine-associated myocarditis. However, the vaccine would prevent 11,000 COVID cases, 560 hospitalizations, 138 admissions, and 6 deaths. And in addition, would prevent a lot of the so-called post-acute sequelae of COVID. COVID there've been a lot of these long haul syndromes, people with taste and smell problems and so on. So next slide. In addition, there is a condition seen in younger people called MISC, or multi-system inflammatory syndrome. This is a condition with severe inflammation of multiple organ systems in the body. And again, is something which affects young people. So 30% occurred between age 12 and 20, with most of the rest being between age 5 and 11. Many of these children required care in the intensive care unit, and some even required very advanced support devices. So what they found was the Pfizer vaccine was 91% effective in preventing MISC in these kids, and mainly prevented the severe forms. So what they found were 95% of children hospitalized with MISC were unvaccinated, and no vaccinated child required life support. So based on all of this, the CDC continues to recommend vaccination of all children, including adolescent males, because in fact the treatment is not worse than the disease. Although there is more myocarditis, the myocarditis tends to be mild, and children recover, whereas allowing them to have the disease is not always so benign. Next. Now, one thing they also found is, one thing about COVID is COVID's different. I've been doing this a long time. I've been out here for 36 years. A lot of what we do is we call evidence-based medicine, meaning that we do things based on large trials of thousands and thousands of people. But with COVID, we really didn't have that luxury. People were getting sick and dying and ending up in ICUs. We needed to make decisions and really try to make policy based on what we thought was the most reasonable thing to do. We literally were on phone calls with China and with Italy and the rest of the United States and other hospitals in New Jersey and Bergen County and so on. So a lot of the decisions were just sort of made based on what you thought was the intuition of what the right thing to do. And I think the CDC did the same thing. So the decision to vaccinate 3 weeks apart for Pfizer or 4 weeks apart for Moderna was one of those decisions. But what the CDC found was increasing that interval to 8 weeks actually reduced the risk of myocarditis. And actually the CDC updated their advice to say that this interval should be used, particularly for adolescent males. So we learned based on what we were seeing. Next. One other interesting, I called it collateral damage of COVID, was a lot of people in the initial phase when this was really rampant just stayed home. So the number of heart attacks and strokes and so on that actually showed up in emergency rooms was less. We expected to see more based on the disease, but in fact, most people were afraid to go to the hospital and stayed home. Next. So what about people who have had COVID? And, do we have to worry about, does COVID affect the heart after people have had it and have recovered from COVID? So this was an article published in Nature Medicine just a few months ago. Next. This is a large trial that looked at VA patients in the 1 year post-COVID. What they did is to compare them to a contemporary group who did not have COVID and then a historical group prior to the pandemic. They looked at 11 million veterans' health records. Next. So what they found was, in fact, that there were 45 additional heart events per 1,000 people. And when I say heart events, I'm talking about stroke, heart failure, heart attack, mini stroke, arrhythmias, pulmonary embolism of people who had COVID compared to the contemporary control group. So that, and the risk of having a heart illness was 58% higher compared to a historical control group. So there's something about having had COVID that actually makes your risk of having a cardiac-related event higher, certainly within the first year. Next. And these really were across the board and higher numbers for sicker people. So the dark blue are intensive care unit, the less dark are hospitalized, and the lighter ones are non-hospitalized. And you can see all of them had excess cases per 100,000 COVID-infected people. The sicker, the higher the number, but even people who weren't sick still had excess cases. Next. So there was a 39% higher risk of developing, and this is people with mild COVID. So these are people who had, runny noses or whatever, were not hospitalized and got better. There was still a 39% higher risk of developing heart problems compared with the contemporary control group. So that means that there would be 28 additional problems per 1,000 patients, 3 times higher risk of myocarditis and 2 times risk of pulmonary embolism. Next. But the one caveat is this study was all done prior to the widespread use of vaccines. We don't know if this is going to apply to people who have been vaccinated and have so-called breakthrough COVID. We just don't know. I happened to see a lady in the office today who was unvaccinated, having some chest pain. She had COVID a few months ago, so she is of significant concern. But what about a person who's been vaccinated and had COVID? We don't know. The study is going on now, but it's something we need to be suspicious about. Next. So what about this post-acute COVID syndrome? What do you look for and what do we do? This actually is an article published in today's journal. I happen to be looking, this is the Journal of the American College of Cardiology. This is the August, I think it's the July 26th or August 2nd edition. So this is right up to the minute. Next. So what they're looking at is people have many symptoms after COVID. Many have chest pain, which may or may not reflect circulation. Many have persistent shortness of breath, fatigue, palpitations. Sinus tachycardia means fast heartbeat, postural orthostatic tachycardia, people who feel their heart racing when they stand up. So these are all symptoms that mean that really should have a person say, I need to see my doctor and at least get checked out. It doesn't mean you're having a heart attack or a stroke or and so on, but at least to someone to ask the question. Next. And some of the things we can do are, baseline electrocardiogram, echocardiogram can help us. Troponin, as I mentioned, is a blood marker of heart injury, stress testing, cardiac monitoring, and then probably the most aggressive test, cardiac MRI. So we have a lot of tools, a lot of non-invasive tools to evaluate people post-COVID who are having symptoms. Next. So in conclusion, for COVID myocarditis, the incidence in COVID people is low, but it is 16 times more common than in non-COVID patients. Men and women are equally affected. The highest risk occurs in adults over 50 or children less than 16. The mortality in people who are hospitalized is high. It mirrors people with severe COVID, but asymptomatic or mildly symptomatic young adults have an excellent prognosis. Next. As far as vaccine-associated myocarditis, the incidence is highest in young men, usually after the second dose and occurring within 2 to 3 days. Unlike the disease, the prognosis of vaccine-associated myocarditis is almost uniformly excellent. The use of the vaccine, therefore, in adolescent males is recommended due to the risk of severe COVID-19 and complications, including MIS-C. and perhaps increasing the interval between doses to 8 weeks may reduce the risk of vaccine-associated myocarditis. Next. Unvaccinated patients in the year post-COVID have a significantly increased risk of heart disease, including heart attack, stroke, pulmonary embolism, DVT, heart failure, and arrhythmia. We don't know the risk in breakthrough vaccinated cases. Next. Thanks for listening. I'll happy to answer any questions that I can.
Thank you, Dr. Sotsky. Let's see what we have for some questions. So if you do have questions, there is the Q&A box at the bottom of your screen, and you can submit those. We do have some time for a few questions. Let's see, are you more likely to have a heart attack once you've had COVID?
Yeah, it's a hard question. So there's no question that if you have not been vaccinated, the answer is yes, unequivocally. That's what that study showed. That was, from the Cleveland Clinic, that was published in Nature Medicine. But if you have had the vaccine and you have breakthrough COVID, we don't know. We don't know yet. My suspicion is you will still see some increase. There's something about the inflammatory response to COVID, but that's not been proven. But I think that, for people in the community, I think you have to take the symptoms seriously, even more seriously, than, and obviously you take chest pain or shortness of breath or fatigue and all that, should take it seriously anyway. But I think in a person who has had COVID, particularly within the last year, they should even take it more seriously, because we don't know if this is going to be another risk factor for heart attack and stroke and so on.
Okay, is there more incidence of myocarditis with Pfizer than with Moderna?
I don't think that's been demonstrated. I think most of the studies that were done, the reason that the Pfizer vaccine was shown to cause more myocarditis, the answer is yes, in the sense that initially the Pfizer vaccine was the first one that was approved for children. So obviously most of the cases were Pfizer cases because Moderna was not given to children. I believe that it has been approved subsequently. So I don't think the feeling is that one is going to be any better or worse than the other. They're both mRNA-based vaccines. Presumably they would do the same thing. But again, in aggregate, there would be more Pfizer-related cases because it was approved first for children.
Okay, how is myocarditis treated?
So unfortunately, there are no antibiotics to treat viral infections. So all we can do is support people. It's been shown that steroids do not help. So what we do is support blood pressure, support heart muscle function. In critically ill patients, we sometimes need to use devices that almost act like artificial hearts. There have even been transplants occurred in very severe cases. The vaccine, the large majority will get better on their own. Even the COVID-related cases, the majority will get better, and the ones that don't, we support with medicines and devices.
Do antivirals lower? I think they're asking if it lowers the risk of getting myocarditis.
Yeah, that's a great question, and I think nobody knows the answer yet, because as I was saying earlier, what's unique about COVID is that it's happening in front of our eyes. So the drugs like Paxlovid and so on are really only recently used in the last few months. So we just have not had time yet to see. But that's an excellent question, and that's going to be answered. We're going to see if the complications of COVID are reduced by the use of antiviral drugs. One would think that there's a good chance they will be, but we don't know that.
Okay, are there any studies on having COVID and 3 months later getting a booster than having symptoms of myocarditis within 24 hours of the booster?
Yeah, it's again a very good question. Because again, the initial studies that I showed you were mostly after the second shot because it takes time to these are very, very large databases. Now, those databases undoubtedly exist for boosters, but I'm not aware of anything that's been published yet. I can tell you anecdotally, I had a woman, and interestingly enough, this was a woman who was 80 years old, who I'm convinced had myocarditis within a few days of receiving a booster shot. So I would suspect that we're going to see some cases related to the booster. It would make sense because myocarditis is an immune based reaction, but I don't think anything's been published yet. So I don't think anybody knows the answer to that.
Okay, is there anything about the current circulating strain that qualifies the conclusions? Not sure.
Yeah, I mean, I don't think so. I mean, we've been hearing a lot about the BA.5 variant, which, as far as its infectivity, I have not heard anything that it causes anything different from the other strains as far as more or less myocarditis. That would be very tough to do because if you look at the numbers that I was showing, we're talking about looking at literally millions of doses, of vaccine and really millions of patients who have had COVID. Typing the variant is not easy. That's expensive and difficult, not that easy to do. It's something that's done, in the standpoint of epidemiologically, they can get a pretty good idea of, what the dominant variant is and so on. But to actually individually characterize each virus, who had what and what their complications were, that would be a very large undertaking. So I'm not aware of anything different about BA.5 from the standpoint of complications.
Okay, if you had myocarditis from the booster, should you get a second booster?
I think not. There was a case, there was one case, interestingly enough, in the series I mentioned, who had myocarditis after the first and then for some reason got a second shot. I'm not sure why, and got a more severe form. So I think a person who is thought to have vaccine-associated myocarditis certainly would not get another mRNA vaccine. Now, I forgot the name of the company that makes there is a non-mRNA vaccine that was just approved. I don't know the answer to that. I think that's a question for the CDC or, the infectious disease people is would they boost a person, who's already had myocarditis? I suspect not.
Okay, I think that's all of our questions this afternoon. Thank you so much, Dr. Sotsky, for the informative presentation and for your time this afternoon.